everyone. This is Fiona Fonseca. I'm one of the associate editors for the American Journal of Psychiatry. And I have with me today Dr. Hossam Mahmoud and Dr. Omar Elhaj.
Hi. Hello.
Hi. Can you tell us a little bit about yourselves?
Sure, I can go first. My name is Hossam Mahmoud. I am a board-certified psychiatrist. I am licensed to practice medicine in Illinois and Massachusetts. Currently, I am the medical director and senior vice president of behavioral health at Regroup Telehealth, which is a telepsychiatry company. And I'm the president of the Illinois Psychiatric Society, which is the Illinois district branch of the American Psychiatric Association.
And I'm Omar Elhaj. I'm a board-certified psychiatrist, currently working in Ohio and licensed in 8 states in the country. I serve currently as the division director for special projects in the Midwest for LifeStance, which is the largest owner of private practices in the country.
Wonderful. Thank you so much for these introductions. So, as you know, we've talked about this before, and the reason that I had you come up to this podcast and talk with us is because I was at your presentation at the APA conference 2019 earlier this year, and you guys both talked about your experience with telepsychiatry, and there was all of this new information that I was exposed to that I hadn't really heard too much about before this. And I was wondering, I'm probably not the only resident out there who hasn't heard much about telepsychiatry, and I was hoping you might be able to share a little bit about your experience in the field. So I'm going to start by just asking both of you, how did you both get involved with telepsychiatry?
Sure. Omar, do you want to go first?
Well, I've been involved with telepsychiatry in one way or another since 2006. Back then I was one of very few psychiatrists in the VA system here in Ohio who were trained in both geriatric and addiction. And the VA then needed to have veterans who lived with addiction diseases who were advanced in age receive the care from somebody who would know both areas. With the VA, one of the nice things is that if you are practicing in one property, regardless of the state, and you are licensed in that state, you can actually see veterans across the whole country if they are located on a veteran affairs property. So they would actually connect those veterans to the clinic I was working in through video conferencing equipment, and I would be able to see them wherever they were. However, the equipments back then and the requirements of a very heavy footprint band to make those video conferencing and telehealth equipments work was much more complicated than what we have right now in this day and age. So that's how I got actually exposed to it. And then I started to do a little bit of it in my private practice when I started to be in private practice. And then in 2017, I met with Hossam and the wonderful team at Regroup, where we were doing telehealth for, across the whole country. Hossam would know actually the exact number of states. And then just about 4 or 5 months ago, LifeStance that actually acquired my practice before I joined Regroup approached me and want me to see if we can actually do direct to patients telehealth in the Midwest. So that's in short, my journey with telehealth. Now I would leave it to Hossam to tell us about his journey.
Absolutely. Actually, I was first introduced to the notion of telepsychiatry as kind of as a almost a public health service when I was practicing in Canada in 2014. This has to do to some degree with the need and the size of Canada. And so because it is much more sparsely populated than the United States, and and is of a much larger size than the United States, Canada has had to innovate and implement telepsychiatry programs across the country many years before we scaled telepsychiatry here. And so that was the first I was introduced to telepsychiatry. There was some telepsychiatry being practiced in more rural parts, although I was practicing in an area that was already rural. There were even more rural parts of that province that were receiving telepsychiatry services. Then I moved back to the United States and was doing mostly inpatient work and consultation liaison work, so not much telepsychiatry was involved in that. However, in 2015, 2016, I was introduced to Regroup Telehealth by a former colleague of mine who was working at Regroup, and they'd approached me about my interest in doing some hours with them, and then eventually the conversations led to me assuming the role of medical director and doing a combination of direct to patient services as well as consultation services, doc to doc consults and e-consults, in addition to assuming an administrative role in the company. And that is how I ended up getting involved in telepsychiatry.
Okay. So both of you kind of mentioned this connection of getting involved in telepsychiatry through networking, which was interesting to me. I guess I had this preconceived notion that a telepsychiatrist would be quite detached and kind of in your own little tower, practicing psychiatry at a distance, you know?
You're actually, that's a very good observation. And this is one of the things that, Hossam and I have talked about, together and in a group. I think if you are a psychiatrist who generally is a stoic, like the isolation, and not want to be interacting with people, I think actually then telepsychiatry is not a good fit for you. Even though telepsychiatry allows a lot of flexibility in terms of work schedule, in terms of life-work balance, if you are somebody who does not like to interact with people, then probably telehealth or telepsychiatry is not good for you for a simple reason. Fiona, in the end, it's about you and the patient. And one of the things that we do in-person health is, however welcoming and inviting we are, it remains our space when the patient enters our office or our clinic. In telehealth, we are entering as guests in the patient's own environment. And really, our footprint is merely a screen that is, the biggest, it's a 21-inch screen in most cases, like what I'm trying now to do in the Midwest, where the patient is seeing me on their iPhone or iPads or laptops. I'm not really much larger than a 15-inch screen. So consequently, your ability to connect and to create a presence actually has to be even more heightened than where you're doing it in person. Otherwise, you're really losing that ability to connect with a patient. I don't know. Don't you agree, Hossam, that you really have to be more engaging in telehealth than in person to make it work for the patient?
Absolutely. I think as a telepsychiatrist, there's a bit more burden on you to be more animated and maybe more bubbly in a way, more engaging. I know Omar has an amazing sense of humor, and I also use humor, particularly when it's patients' first time interacting with a healthcare professional over video, and there's either a degree of skepticism or discomfort. And so there is more of a responsibility on the end of the psychiatrist to be more engaging.
And to be more present with the patient too, it sounds like.
Absolutely.
Yeah. So Dr. Mahmoud, something you mentioned was that you were doing telepsychiatry in Canada before coming to the US.
Yes, to some degree, but I wasn't practicing telepsychiatry on as regular a pace as I have been over the past 3 years.
Would you be able to speak at all to what the differences are in terms of how telepsychiatry looks in Canada versus in the US?
Yes, I'm happy to. So the technology is pretty comparable. There's a very advanced degree of connectivity when it comes to bandwidth. And even rural parts of Canada tend to be pretty well connected to the internet. The factors, though, that do make a significant difference are issues that allow for scalability. Historically, in the United States, we have not had as much support from a reimbursement perspective for telepsychiatry. This has definitely changed over the past few years, but there remains a lot of restrictions on reimbursement, whereas that did not constitute a barrier in Canada. It was part of the public health policy of the province to ensure reimbursement of telepsychiatry services.
Absolutely. I mean, I can speak even more on that. Now that in the past, month, since I left Regroup and now I'm working with LifeStance, Hossam, you're probably, very well aware, but I can't just, tell you how challenging it is. So on the surface, for example, when you talk with a payer, about telehealth, private payers, and everybody from the top supports you. Oh yes, we need to do it, and we are engaged. But then you need to check with the individual plans of every single patient. So one of the nice things that I'm working right now is in Kentucky, for example, where they have by law parity in both coverage and reimbursement for telehealth. While, for example, in Ohio, where I am physically located, they don't have that. Each plan is very unique, and each plan has certain clauses about telehealth or does not. So, in Canada, and I remember, Hossam, when you and I were working on one of the articles, a lot actually of the effectiveness of telehealth in its multiple forms actually was generated in Canada. And then it became more prevalent in terms of research to do it in the U.S. So I think actually Canada has done really a very good job in establishing telehealth effectiveness in terms of literature.
It sounds like there's a vast difference between the way telepsychiatry is received and reimbursed in Canada versus in the U.S. And then even within the U.S., the different states seem to approach it in different ways. So how do you go about setting up a practice with all of these differences?
Wow. So that setting up a practice can be challenging, particularly if you are not familiar with the reimbursement laws of the state, as well as the variation that exists within every state when it comes to third-party payers. So private insurance have different criteria for determining whether they would cover telehealth services, and even within one company, different plans can be very different. Even different PPOs can be very different with regard to what they would cover or not. And so the first step would be to familiarize yourself very well with the patient population you'll be working with and the kind of health benefits or insurance coverage that they have. In order to assess whether establishing a telepsychiatry practice is sustainable for you, and we're talking about telepsychiatry within one state right now. So if you, as a psychiatrist, want to set up a telepsychiatry practice, you would have to examine the needs within the community, the patient population you're going to serve, and kind of by extension, the kind of reimbursement you'd be able to get.
And something you'd mentioned, Dr. Elhaj, was that you're licensed in 8 states.
Correct. Yeah. Actually, Regroup was was the team that helped me get, licensed in 8 states. And we found that the requirement, to do telehealth is very different between one state and another. There is something called the National Compact, where certain states actually now do have agreements within each other, where if you are licensed in what they call your home state and you meet certain requirements, the other states would actually license you to do telehealth, in them. Some others, you have to be fully licensed in the state where you are seeing the patients and in the state where you are residing to be able to provide telehealth services. One of the things that, Hossam, like I'm now trying to do is to create kind of like a hybrid model where, for example, this currently the, LifeStance has different practices in Kentucky, in Ohio, Missouri, and Indiana. Those are the practices that I'm working with. So the first one that I'm going to be starting to establish telehealth with is called Beaumont, and it's in Kentucky. And what we're trying to do is kind of create a hybrid model initially, where the patient already comes to your office and already established the relationship. And if their insurance allows for telehealth, what we're trying to do is, after, a while, if you are interested or if the provider is interested, the provider of healthcare, then you can convert it if you want to telehealth.
It sounds like gives the patient all of this flexibility where they can see you in person and then maybe switch to seeing you remotely and then in person again, if depending on kind of where they are.
One of the scenarios that crossed my mind is like, well, if somebody is having, panic attacks and agoraphobia and can't leave their house, actually it would be a great, for them to be able to use telehealth, until they're better. But then, probably at some stage, I would like actually for them to come to the office and, wait in the waiting room, interact with the front desk staff and drive to come to see me to see actually, well, the work that we did in telehealth made a difference in their actual life. So I'm seeing like some, making a hybrid model actually might be beneficial to the patient rather than just to offer one way or the other.
What about, since you mentioned something like agoraphobia, have you ever been in a setting where, say, the patient has you on their phone and they're taking you with them to the grocery store or things like that? How does that work, or does that work?
Hossam, do you want to talk about that?
In my practice, I see patients who are physically at their local healthcare facility and video conference in to connect with me. But I don't see patients at home or using their phone or iPad.
I started recently, Hossam, and I can't tell you, how revealing it was. So there's this person, and she has severe OCD, depression, and hoarding. And what she let me see in the house was really worth, 1,000 words to describe, the severity of the hoarding that she is experiencing. It was just eye-opening.
Wow.
Yeah. So it sounds like you were really able to see a...
Yeah, because you have a window to the person's, really we always talk in psychiatry, like when we got trained, they always tell you like, you have to have criteria A, in DSM-5, they list the symptoms, and then like the criterion, what is it, like C or D, it talks about how severe those symptoms and the impact on the person's life and, domains of functioning, whether it's work, home, interpersonal, and so forth. And you always, ask about those when, you're interviewing your patients, whether for the first time or, later on, just to understand the impact of the symptoms or the impact of the improvement in the symptoms on those domains. When you're doing telehealth in their own sphere of functioning, and see it with your own eyes, how it is that these symptoms impacting, it's more eye-opening, and it really reveals a lot about the severity of the symptoms, or hopefully with the treatment, the positive impact on their life.
And then you can see as their surroundings change too over the course of their treatment with you, right?
Absolutely.
Yeah.
Wow, that's amazing. That's amazing. Yeah.
That is really, really cool. Yeah. And then I'm wondering, since you're working from home, how does it work in terms of switching off from work? Because you're like, to someone who isn't doing telepsychiatry, home is their downtime. So how does that work?
I think it's very important to have a home office from which you work, and from which you can provide care. An office with a professional background that is quiet, that is private, because we want to maintain, of course, patients' privacy, but also a home office that you can leave at the end of the day and actually close the door, and hopefully not go back into that office for the rest of the day, to be able to almost physically disconnect from the work setting.
One of the things that you need to be very careful about is to have a clear demarcation between, your family life, your house chore duties, and your work. So then you're not being pressured to play a role during the time that you're not supposed to be playing that role. One of the things that now I have appreciation of when I worked from home, and I didn't appreciate as much, is, I still do some work from home, not to do telehealth, but when I have some admin work and I want a super, focused time, there's a nice thing about being home and just having no interruptions. It's like, I have, 110 focus on what I'm doing. When you are in the office sometimes, and especially if you have a tendency like myself just to like to talk to people, and, distraction sometimes is a nice thing. I don't have the ability to focus on things as much when I am in the office as, when I'm home. So I do miss that.
So I have to ask the question, since, I was talking about this interview with a couple of my colleagues, and we're talking about this overlap between home and work with telepsychiatry. I have to ask, do you guys wear like formal pants and belts and all of that when you're doing telepsychiatry?
Heck no. Hossam does. Hossam is much better than me. When I was working at home, I was wearing sweatpants. I would wear like a nice shirt and sometimes, a tie, but just like, there's, it just, there are pants, but they're not like, dress pants, just the sweatpants.
So let me clarify. I do not wear dress pants and belts. I do wear jeans though, and because I feel that I need to not be in kind of house clothes when I'm working, and so so it's not as formal as I would have worn if I were seeing patients in person, but it's still kind of a pair of jeans.
So a little bit of a mindset related thing. Yeah. So we're going to shift gears a little bit. I wanted to ask a little bit about what, your hours look like.
Actually, it offers you the ability to predict your schedule to a higher level of certainty than when you are doing the same clinical work from, the office. Because unless you live in a rural area yourself, the variation in traffic and other demands really impact your schedule. So if you're doing telehealth, especially from home, by the time you're done, unless there's an emergency with your patient, but generally by the time you're done, you're just done. You don't have to worry about, shoveling the snow to get to your car, or, the traffic in San Francisco, New York, or in Chicago for that matter. So, it does actually offers a lot of control. Especially, let's say, Hossam and I always talk about this. I mean, I think actually telepsychiatry, especially whether it's hybrid or not, it offers, if you have demands on your life outside of work and that you really need to meet them, whether it's raising a kid that you need to pick up from school or an elderly parents that you need to take to a doctor or to other places. Telehealth and working from home does offer a larger extent of freedom and flexibility.
There are days off, just like any other setting. So if you're seeing patients on an outpatient basis, you're most likely not working on Saturday or Sunday. If you're doing inpatient work, there's variation, but typically, if you are the main attending on an inpatient floor, you will be working Monday through Friday, and then there is call, there is weekend rounding, but that these scope of services tend to be different and handled differently within telepsychiatry, in the sense that as a telepsychiatrist, you can choose to work inpatient and do 5 days a week, but do absolutely no call. You could choose to do only weekend rounding and not work during the week, or do inpatient weekend rounding and then do outpatient for 1 day a week. That's the great thing. When we talk about the flexibility of telepsychiatry, is that it does allow you to work in multiple settings beyond geography, especially if, like Omar, you're licensed in 8 states.
So since you mentioned inpatient telepsychiatry work, how does seclusion and restraint law kind of change for telepsychiatry, or how does that work?
Yeah, that's an excellent question. So as you mentioned, there is significant variation in different jurisdictions, with different states and even different districts. The patient can still be seen via telepsychiatry using video conferencing when there is need for seclusion or restraints. There is another component to that, in that the patient also needs to be seen by a hospitalist or an internal medicine or primary care doctor at regular intervals while they are in restraints. And that does not change, of course, and there's significant variation between states. So it doesn't, mental health law does not change, and just because we're doing the work remotely does not mean that we are exempt from mental health law. On the contrary, there's a lot of dedication to following the mental health law. And because with telepsychiatry, everything is time-stamped, you can actually monitor the quality of the services much more easily than if it were in person.
Absolutely. And I think actually it allows, I mean, I'm glad, Fiona, you brought this example, because when I argue about the utility and the effectiveness of telehealth, actually this would be one of the examples, because when you're using telehealth, you're able to bring that attending on a laptop to that room within that exact time requirement. You don't have to wait for her or him to drive, in the middle of the night or in the early hours of the day to go and see that patient. And I just wanted to actually mention something, like the Joint Commission, that, at Chris Hospital, they determined that they did not need to come up with specific and separate standards of care for telehealth, because they deemed that, the currently existing standard of care for in-person could apply and should apply the same way to telehealth. So, to be very candid with you, especially for those situations, I actually believe that having access to telehealth might actually provide the patient with much more efficient and readily service than waiting for the in-person, or, for example, for, an ER visit. I mean, how many times somebody would need to go to the ER with suicide ideations or with a psychiatric emergency, and then they get assessed by the ED physician, and they wait, sometimes an hour or so to be seen by a psychiatrist or a psychiatric nurse practitioner to come physically to see them in the ER. If they have access to, to psychiatric telehealth services, I mean, that could, make it much easier, and that would decrease the distress of the patient having to wait, not knowing what's going to happen to them. And it's going to improve the workflow in the ER, equally. So I wish actually we think more about telehealth in those, more acute settings. I mean, people think about telehealth, just for the outpatient or just remote areas. I strongly believe that for the acute settings, utilizing telehealth could be, in some instances, truly lifesaver.
So we're talking about access to mental health care and improving access to mental health care across the board, really.
Absolutely, yeah.
Yeah, right? And then this need to be familiar with mental health law for all of the states that you're working with.
Absolutely. I mean, and one of the things that Hossam and I always, talked about in the past few years is that, we need to remember that one of every 2 counties in the United States of America does not have access to a psychiatrist.
So since you mentioned earlier, working with with psychiatric nurse practitioners, I'm wondering, there's a role for telepsychiatry and psychiatrists working remotely, but have you also seen psychiatrists doing remote supervision for more mid-level clinicians? And what are your thoughts on that?
Yeah, I mean, both Hossam and I actually engage in that. And it just, it is very effective, very helpful in reducing the shortage of service. And it's, especially with that regard, it's the same, if not even more effective than in-person collaboration and supervision. It makes all the difference. Hossam collaborates regularly with several nurse practitioners. When I was working with Regroup, I collaborate with a nurse practitioner while she was working in Michigan, and I was living, in Ohio. And currently, I collaborate with a nurse practitioner working with us in Indiana. So it's when you're able to establish and sustain a human connection, and you're able to effectively exchange information, you can do it, in person as effectively as in telehealth.
Yeah, and the really great thing is over the past few years, several states that used to require that the collaborating physician meet with the nurse practitioner in person, these states have gradually moved towards eliminating that requirement and allowing for collaboration to occur remotely, either via video conferencing or via phone.
Okay, so do you guys do any face-to-face meetings at all with the nurse practitioners?
Well, to be frank with you, I consider video conference face-to-face.
And then what about with the patients? Do you do any initial in-person meetings with them at all? I'm trying not to use face-to-face again.
I did not mean to to make it sound no, but actually, I had to watch my own language. Just like it's face to face. Yeah, I'm showing my face to the patient on the screen. So that's what I kept using now, in person.
Yeah. So actually, most states right now do not require an in-person evaluation in order to establish a patient-doctor relationship, and therefore you don't have to. In most jurisdictions, you do not have to evaluate a patient in person, and a video conference that is live, or what we refer to as synchronous video conferencing, is sufficient to be able to establish a patient-doctor relationship and prescribe medications or do psychotherapy.
Got it. And then, in that context, then how does it work if the patient is in a crisis? Say, you're seeing them remotely and they say that they're going to go off and do something or that they have a gun on them. Because like for me, I have no experience with telepsychiatry, and I know that if it's inpatient, they're right there and you can ask staff to come in and help with that management. Or if you're seeing them outpatient, they're still in the clinic, you can call the authorities that you need to contact, and they're still physically there at the clinic. How does it work when they're in a different location from you?
Yeah, so the form or approach to telepsychiatry that we have at Regroup is what we refer to as an integrated approach to telepsychiatry, and that entails having the telepsychiatrist integrate into the workflow of the clinic as well as the technologies of the clinic, including the video conferencing that's HIPAA compliant and the electronic health record and e-prescribing systems. So in this model or approach to care, the patient comes to their local healthcare facility, and then someone in that healthcare facility helps them connect to the psychiatrist. Therefore, in this setting, there's always someone around who is dedicated to patient care at that site in person. Of course, in many states, in an outpatient setting, you are not allowed to hold the patient against their will, and all you can do is try to negotiate and de-escalate, and then possibly call 911. But it's great the fact that there is someone in the clinic who is dedicated to that telepsychiatry program and dedicated to patient care and to ensuring that the services are successful. And that person would definitely step in and assist the psychiatrist if there's agitation, decompensation, any suicidal ideations. And that, in a way, that makes this approach to care less anxiety-provoking for many psychiatrists because of that kind of controlled environment.
What about when the patient's at home, though?
That's a very good question. So this is what we're trying to do here, and one of the practices that I've been working with in California, actually they've been doing telehealth with direct to patients for the past 5 years, and what they do is they have a requirement, negotiate with their patients when they agree that they want to do telehealth, is they need to let their doctor or therapist know where they're at when they're doing the telehealth encounter. So either home or office, or whatever it is, but they need to know where that, and they do not do any while the person is driving. So that they are in a physical location, and in any outpatient setting, as you've seen, Fiona, in your training, that they do have a protocol. So, for example, I can tell you about the protocol in our physical clinic here. When a patient in my office is talking about suicide, and I'm deeming that they need to be in the hospital, we have an instant messaging system that I immediately send a message to my support staff, who call the police and initiate the protocol. Now, like Hossam said, if the patient actually decides to leave, I cannot physically hold them or prevent them. I don't have that authority by law, so I need to let them go. So consequently, it's not that much different if they are home and they're starting to talk about suicide, and I am concerned about their safety or the safety of others. I actually do the same thing. I send an instant message to my support staff here in the clinic, who immediately call the police. They call 911 and they give the patient the address, of where the patient is. So, yes, I am not with him or her physically in that location, but my ability to intervene to reduce, the risk as humanly as possible is not that different. Because again, that's one of the things that I keep reminding people with is exactly what Hossam said. If they are in my office and, they decide to leave before the police shows up, I can't do anything, So it's the same thing if they are in their office or in their home. And it doesn't make, much difference.
And I'm guessing in those situations then too, kind of more from I guess, a selfish, self-preservatory perspective, the psychiatrist would be safer if the patient was homicidal because the patient is far away from you physically.
Absolutely. That's actually one of the things that Hossam and I talked about in the paper that we published, which is, that's one of the advantages of telepsychiatry, and part of the reason why telepsychiatry has been utilized very widely and effectively in correctional settings is that you're able to work with potentially violent patients, or patients who might harm you in the safety of your office or your home, and provide very effective treatment without exposing yourself to any danger.
Yeah, and that also applies largely to emergency room departments. So doing emergency room evals via video conferencing is actually safer for clinicians, because emergency room departments tend to be unpredictable, chaotic, and at times just flat out dangerous.
So what are the settings that you guys currently work in remotely?
I currently do outpatient telepsychiatry at a freestanding community mental health center. And I do doc-to-doc consults with a healthcare facility in rural Illinois. I also do e-consults through an electronic health record system. And I have done resident supervision via tele. I have also collaborated with nurse practitioners via telepsychiatry.
Yeah, and then when I was working with you, Hossam, we did IOP. I know actually a facilities does PHP, inpatient work, ER settings, nursing homes, if they are in Medicare designated shortage areas, also could actually, telehealth could work very effectively with. I wish Medicare would change their rules and move it more openly to use telehealth, not just necessarily in those strictly designated areas, because when I think probably one of the best utilities for telehealth is, especially like in the weather that we have in, Chicago or Cleveland or Michigan for that matter. When you are in the winter, I don't want my 85-year-old, patient to be walking in the wind or the snow to come to see me, or especially if somebody is in a nursing home that is a frail, being able to have access to a telepsychiatrist when they need them, not when the schedule of the psychiatrist allows, for them to go there. I think it would revolutionize the care.
So it sounds like your patient population then too is quite diverse, since you're working across all of these different settings and really able to reach people who are like older and then younger and then of all kinds of backgrounds.
And that's the nice thing. Yeah, that's the nice thing, about telepsychiatry, is that you are able to diversify your clinical work to include different populations and different settings that you might not be able to as easily do when you're doing in person.
So I know we talked about a lot of the strengths of telepsychiatry, and it really sounds like something that would really positively impact the future of our profession in a way. But what do you see as some legal and ethical concerns that come up with telepsychiatry?
When it comes to ethical considerations, I think there is some challenge when practicing telepsychiatry with patients who are at home. If there are situations where their background might not be, or their setting might not be as private as you would like it to be, or in cases where there is some kind of family or partner abuse and someone is present in the room without you being able to see them. These are some of the ethical issues. Some of the other ones are the lack of access of many people still in the country today to high-speed internet that does allow for good quality video and audio. And so from a social or a health justice perspective, if we were to shift to solely telepsychiatry, that might leave out many patients. These are some of the issues that kind of come to mind. I don't know, Omar, if you've thought of any other ones.
No, I agree. Actually, I think you covered it well.
I think that brings up a point that is pretty important. There are a lot of resources out there for both clinicians and for patients that pertain to telepsychiatry. The American Telemedicine Association has developed guidelines and best practices for the implementation of telemental health services that are available online, literally by just Googling them. And then the American Psychiatric Association has partnered with the American Telemedicine Association to also release some guidelines on best practices for telepsychiatry. So there are a lot of resources out there, particularly on the American Psychiatric Association's website.
And they are very helpful. They're very useful. And they do cover, like especially the ones on the APA website that Hossam referred to. They do actually cover a lot of aspects from the history of telepsychiatry to how you set up your practice to talking about effectiveness to reimbursement to legal issues. So it's very, very thoughtful content that we have on the APA website.
They even cover, I can't remember right now whether it's the American Telemedicine Association or American Psychiatric Association, but it is also easy to find the criteria that are necessary for an adequate treatment consent or consent form for patients. Yeah.
So since you mentioned these resources, I'm wondering, for, again, kind of shifting gears a little bit, for residents who are interested in getting telepsychiatry experience or training, what recommendations do you have? And then maybe you could pull a little bit from what sort of training you yourselves did to get involved with this field.
Actually, we are exploring moonlighting opportunities, and Regroup does offer training both on the technology, but also on some workflow and kind of clinical aspects of providing telepsychiatry. However, we are in talks with a couple of healthcare facilities who are interested in offering electives for patients in their fourth year. Who would like to get some telepsychiatry experience.
That's really interesting. So I know you mentioned Regroup and you guys are very involved with them and they've, it seems like, had a really formative experience on the way you both interact with telepsychiatry as a subspecialty nearly. But, I understand that there are multiple telepsychiatry groups in existence. How would, say, a resident is interested in getting involved with telepsychiatry, what kind of questions would they need to ask to make sure that a certain group is a good fit for them?
First of all, I mean, what the resident need to look at is that, the value and the mission of the company. What is it they're after? And how do they treat their providers? Number two is just like any job. I mean, you need to look at the culture of the company and does it actually, fit you? It's not just about what is it that we could do, in our jobs. It's also about, what is the job is going to do to us, positively and negatively, and look at that.
I would add that when kind of evaluating different telepsychiatry companies, it's like evaluating different healthcare organizations when you're looking for a job, or rather nowadays as a psychiatrist, if someone is pursuing you, because chances are you are being pursued more than you are pursuing a job. I would look at two very critical factors that for me are very, very important. One is a clear dedication to quality of care. And The other aspect would be transparency. These are the two components that I value the most about any job that I have ever had. And these are the two components that matter the most to me when I think about my satisfaction with my job.
Do you guys have any thoughts on why we're not using it more, or what the obstacles are to using telepsychiatry more and how we maybe overcome those?
Number one is reimbursement. And then in my mind, and like I said, when we started the conversation earlier today, is that not in every state they have laws enacted to ensure parity in both coverage and reimbursement. So unfortunately, until we achieve that, it's going to continue to be a challenge.
So I really appreciate this really transparent discussion, both of the pros and cons. And it sounds like there are still quite a few barriers that need to be overcome to make telepsychiatry more widespread. I'm wondering, for both of you personally now, what are the biggest pros to doing telepsychiatry? If you had to pick like one or two most important reasons why you're doing telepsychiatry.
I can start. Number one, access of care. To be in an office in Cleveland, Ohio, and being able to connect to someone in Two Lake, in Northern California, who has not left her little village in 10, 15 years because of her anxiety, that was tremendously motivating, meaningful, and gratifying. So to me, access to care, the improvement of access to care is paramount.
But on a personal level or a lifestyle level, I love being able to work from home and having a 30-second commute.
Well, this brings us nearly to the end of our interview. But before we kind of wrap things up, I'm wondering if you had to give us again some like essential 101 information for residents to take away from today's conversation, what would it be?
You should at least give it a fair chance to see if it would fit in your career plans.
I definitely agree with that. I guess I would go back to the very basics and to the very kind of basic notion of really just defining what telepsychiatry is. And it's the use of technology, telecommunication platforms, and other communication technologies in order to deliver psychiatric care remotely. Most people will find it very gratifying and valuable to be able to serve underserved populations. And so it is definitely worth a try.
Thank you so much, both of you, for sharing, your experience and your insights. I think residents will have a lot to take away from this.
Thank you so much for